So very good evening to all the HCPs who have joined in large numbers for today's webinar on a Monday evening. The topic for the discussion today would be to look at the role of ACE inhibitors, how they have shaped up versus the ARBs in improving the cardiovascular outcomes. So this is a 1 hour panel discussion wherein we have our moderator who has given us this opportunity, and we are really thankful to Dr. Rajiv Garg sir for providing us with this opportunity. Sir is a senior consultant interventional cardiologist and is heading the department in Gleneagles Aware Hospital at Hyderabad. I welcome you on board, sir. Thanks for your valuable time.
Okay.
And the panel for the discussions who will be helping us to know more about the role of ACE inhibitors and ARBs in the cardiovascular outcomes would comprise of Dr. Deepak Krishnamurthy sir, who is from Bangalore. He is a senior consultant cardiologist and head of the department at Kaveri Hospital. I welcome you, sir. Thanks for your time, and we look forward for your insights, sir. Please also join me in welcoming Dr. B. Vinod Kumar, who is associate professor, senior consultant interventional cardiologist, working at Sri Ramchandra Medical Center in Chennai. I welcome you on board, sir. And finally, Dr. Karunakar sir, who is a senior consultant interventional cardiologist at Apollo Hospital in Hyderabad. So this will be our panel experts who will be helping us with the discussions. So in the next 1 hour, we will look forward for gaining insights from all the eminent faculty today. So without much ado, I would now hand over the session to Dr. Rajiv Garg, sir. So over to you, sir.
Yeah.
Right.
So, thank you, Dr. Anup. Thank you, MQ, for enabling us a lively topic and always debatable topic, ACE versus ARB in the CV outcomes. So let us hope our discussion becomes fruitful with esteemed panel of Dr. Deepak, Karunakar, and Dr. Vinod. And the format of the colloquium is I will present the evidence-based slides and then take your opinion according to the questions. And let us see the common consensus after that. So to begin with, are my slides visible?
Yes, sir.
Am I audible?
Yes, sir.
Audible. Yes, sir.
Fine, fine. So let us begin. So today's panel discussion revolves around emerging evidences over a decade in the era of hope and life trial for ACE and ARB in primary prevention, then recent evidences from meta-analysis and randomized controlled trials, the importance of value trial and ARB-MI paradox concept, are there differences in opinion, and post-MI evidences for mortality benefit of ACE versus ARB, and post-revascularization, which is the drug of choice, ACE or ARB. To begin with, let us take the first part of the story, the era of hope and life, where we tested ACE inhibitor in hope and ARB in life. Hope tested ramipril and life tested losartan. So the hope study had 9,297 patients. They were high-risk patients with evidence of vascular disease or diabetes. 3,500 were diabetic, and one or more risk factors not known to have heart failure. So they were not used in heart failure or low ejection fraction. The dose of ramipril, we should know, is 10 milligrams used in the trial versus a placebo. Follow-up period was 5 years. Highly significant reduction in primary endpoint of death, MI, stroke, and coronary revascularization was seen in all the patients using the drug. The diabetic subgroup showed higher benefits than the non-diabetic subgroups. Benefit of ACE inhibitors over and above BP control was seen, and there was 30% reduction in diagnosis of new onset diabetes. So this was published in NEJM 2000. What were the primary outcomes? The effect of baseline therapy over and above the aspirin, beta blockers, lipid lowering drugs, diuretics, antiplatelet, and calcium channel. By addition of 10 milligrams of ramipril, stroke reduction was 32%, cardiovascular death reduced by about 26%, non-fatal MI by 20%, and all-cause mortality by 16%. And this was significant value P001 attained in most of the levels. The live trial, it was a double-blind, randomized parallel group trial for patients between 55 to 80 years having essential hypertension, left ventricular hypertrophy based on the ECG criteria. Used losartan 50 versus atenolol. Dose increased to 100 milligrams per day for losartan, followed up for 4 years, and the results showed losartan group showed relative risk reduction of total mortality by 20%, stroke by 25%, and new onset diabetes by 25%. Losartan was better tolerated than atenolol, and rate of recurrent MI remained the same in both groups. Then, in diabetic subsets, the role of losartan, double-blind randomized parallel group trial in which patient was diabetic, hypertensive with LVH by ECG criteria, about 1100 patients were given losartan 50 and 200 milligrams once a day versus atenolol 50 to 100 milligrams once a day, followed up for 4 years. The results, losartan group showed a relative risk reduction of mortality by 36%, MI by 17%, and stroke by 21%. It was published in Lancet 2002. The new concept what they want to propagate is something called as ACE plaque activity. So this is the possible mechanism by which anti-atherosclerotic mechanism of ramipril comes into play. There is an endothelial dysfunction which is reduced by use of ramipril 10 milligrams. Then there is also an action of ramipril 10 grams on plaque ACE activity and local mediator activity. So both of them are angiotensin 2 receptor blockade, but at local level, when there is an increased pi1 which causes thrombosis, is reduced by what you say ramipril. The VCAM, ICAM, and cytokine which cause inflammation is reduced by the use of ramipril. Endothelin, which causes vasoconstriction, also is reduced. Then the plaque is the new concept in which there is an increased bradykinin and nitric oxide. It is reduced by what you say use of ramipril. Growth factor reduction, vascular remodeling takes place, and decrease in the plaque rupture is seen by the use of ramipril 10 milligrams. So this was what was propagated as the plaque ACE activity. The most important factor is there is a direct dose relation between ACE inhibitor and the effect. You can just see 10 milligrams of ramipril was used in ROSE, HOPE trial. The effect of various doses of ramipril on circulating plasma and local plaque activity is seen in the following doses. The circulating plasma activity starts at a low 2.5 milligrams, which is not having local ACE activity. But when you go up to 5 and 10, then you can see the local plaque activity apart from the plasma activity also. The plasma activity is responsible for the anti-hypertensive effect, whereas local plaque activity is responsible for anti-atherosclerotic effect. The clinical impact of this is there's an absolute risk reduction of 3.8%. The number needed to treat is about 26 patients over a period of 4.5 years. It prevents 1 CV death, MI, and stroke. Wide range of patients with vascular disease and a high-risk population, that is 4% annual event rate is seen in this group of population. The HOPE and SECURE study also studied the effect on intima media thickness by use of carotid ultrasound. It included 732 patients, followed up for atherosclerosis for 4.5 years with placebo versus ramipril. And what they found is the progress of vascular hypertrophy, that is intimal medial thickness, over a period of 4.5 years in placebo was 0.098, whereas in ACE group it reduced to 0.062, a 37% decrease by the use of 10 milligrams of ramipril. And hence, there is definitely a decrease in media thickness by use of this one. And so progression of atherosclerosis is definitely dampened by the use of ramipril. Question to Dr. Deep. What is the dose that you would suggest for high-risk patients for atherosclerotic, anti-atherosclerotic property and for preventing of plaque rupture? I stop sharing here and let Dr. Deepak give his opinion on the question asked. Then we can take the opinion of Karnakar and Dr. Vinod also if they are interested to answer. Okay, yeah. So Dr. Deepak.
I think the trial data is clear on this, that to have pleiotropic effect of ramipril on plaque stabilization, you need to give 10 milligram per day of ramipril. The HOPE trial, which included the largest number of high-risk patients with risk factors, very clearly demonstrated this. And now we know over years of experience that 10 milligram per day of ramipril is what is required to achieve this effect and prevent vascular events, be it myocardial infarction, stroke, other major vascular events. One need to use 10 milligram per day.
What is the percentage of patients in your clinical practice achieving this dose?
I would say at least 40 to 50% of patients achieve this dose because fortunately ramipril does not cause too much of a hypotensive effect. And when adequately titrated over a period of time, 10 milligram per day can be easily achieved in 50%. I would say in if patients' initial blood pressures are high, even higher percentage of patients can achieve. But overall, I would say around 50% definitely can achieve 10 milligram per day.
Yeah, for the sake of audience, I think we should try to achieve 10 milligrams. Though in Indian subsets, most of the practicing physicians stop at 5, but we should definitely give a try of 10 milligrams. Now, what is the side effects you see when you're using 10 milligram versus 5 milligram?
The dry cough, which is the commonest side effect we see, is not actually dose dependent. It can develop even at 1.25 milligram or 2.5 milligram of ramipril, and it doesn't increase with the dose or decrease with the dose. But yeah, hyperkalemia, hypotension does become more common at 10 milligram, requiring a decrease in dose and retitration. So what we finally achieve is a maximum tolerated dose rather than the optimal recommended dose. But yeah, if the body weight is low and the initial starting blood pressures are not very high, we may not be able to achieve 10 milligram in all the patients, because at the end of the day, quality of life, avoiding postural drop in BP, and symptoms like dizziness and lightheadedness, especially among elderly people, is not desirable.
Have you seen something like patient using ramipril for a year or two and then developing cough? Very many a times ENT surgeons do refer to us that cough is not our problem, but it is basically ACE related. And we have seen the patient not having that problem for 2 years, and after 2 years, suddenly they start developing this.
I have seen most of the time they're developing in the initial few days itself. But sometimes what happens is if they haven't come back to follow up with us, they have been following up with a physician or some other specialist for cough. Sometimes it does get overlooked that ACE inhibitor could be the reason for cough. They undergo multiple tests, including CT scan of the chest, endoscopies, PFTs, keep taking medication. And then finally, when they revert back to us, we tell them that it is the ACE inhibitor, and which requires either, if it is mild, just an explanation, or if it is severe enough, changing over to ARB may be required. But what I have seen in my experience is most of the time it happens in the initial few days or weeks itself.
Yeah, because we in our practice nowadays are seeing late onset also. The patient does follow up with us and he did not experience, but we are seeing these cases also nowadays. Okay. Dr. Karnakar, Dr. Vinod, do you want to add anything on this question, what we asked? Or let us
so far, I think so we have to educate our physician colleagues to increase the dose if the patients are not following with us. So they will stop at 2.5 or 5 max, and they think that is the maximum dose. But whenever possible, if there are no contraindication, no side effects, any drug, not only for this drug, any drug, better to achieve the target doses. And in the trials, all the benefits are with the target doses, not with the starting doses. So we have to educate our physician colleagues to to subsequently increase the doses to achieve the target level doses. That's one important point I'd like to add.
Dr. Vinod, do you want to add anything?
So probably I keep like this, sir. If my patient is able to tolerate a particular dose, so a lot of times when we go for 10, as the previous speaker was discussing, it is very difficult to tolerate for some patients. So most of them tolerate well with 5 mg. But if the pressures allow us, and if they are symptomatically open, I obviously go up on this dose. So probably in my practice, I'm achieving 10 mg, about 30% probably, in whom we are using Ramipril. Most of the patients, in 70%, we end up slightly little lower dose when compared to 10. If they are tolerating, no doubt, obviously we have to go for 10 mg. That should be our idea. Cough, as you said, morning, late night cough, at the initial period is there, sir, but when, as sir was mentioning, when they try to come back, it is very late. Certain nowadays, there is a kind of awareness where certain people tell them that you have to go back to your cardiologist to check your medications, because there might be an issue with your drug. So that kind of awareness, if it is there, that would be a very great thing.
Yeah.
So, but that percentage is very low, sir. It's not always there.
Yeah. So I think at the end of this first small bit, what we had, 2 messages to be given to our, colleagues. Try to achieve maximum dose. If you have side effect, then we can switch over to other drugs. And most important is the emerging evidence of ACE anti-atherosclerotic effect. So you just see it is not a plain anti-hypertensive drug, but also helps in reducing atherosclerosis, and hence try to use this drug in full dose where the hypothesis was tested. So going to the next aspect. Now, the second effect was the hypothesis of blood pressure independent effect of ACE. This is BP LTTC regression meta-analysis. So apart from the usual blood pressure lowering effect, it had an effect on coronary artery disease. For any given blood pressure reduction, ACE also reduces the risk of coronary heart disease by 9%. And the p-value was 0.002. Independent of the effect of blood pressure lowering. So this was one good finding which was seen. Then angiotensin 2 receptor antagonist, ARB, did not have an independent effect on coronary artery disease. They were just purely blood pressure lowering drugs. And there was a small but non-significant increase in the risk of harm. That is almost, we'll come to later in the slides. 7% patients did experience a increase in myocardial infarction rate when they used ARB. Then most important is the BP-LTC regression analysis showed a 15% reduction of MI CV deaths, which was statistically significant, P0001, between ACE and ARB trials. Now you just concentrate on blue circles and green circles. The green circles are ARB trials and blue is ACE trials. So Valheft, CHARM, LIFE, RENAL, CHARMAD, and CHARM3. These are the ARB trials, and the ACE trials, Europa, HOPE, STAT, SCOPE, and PEACE and PROGRESS trial. What they saw was there was a 15% reduction of MI and CV. The use of blue line. You can just see this blue line, and this is the green line for ARB. So the difference was 15%, which was statistically significant, 0.001. And within the systolic difference, this is very important. Then ACE inhibitors reduce mortality in hypertension. This was a meta-analysis of randomized clinical trial involving 158,998 patients, published by Van Wark et al. And it is a very important hypothesis where we have seen the impact of ACE and ARB on all-cause mortality in hypertension. The ACE, various trials, you can just see the important one, ALHAT, ANBP2, BP2, Pilot, HIVET, then GMCB, ASCOT, BPLA, Advance, HIVET. So you just see favoring the use of ACE. This is a forest graph, and control was better. All the trials showed ACE inhibitor had a better effect, except Pilot, HP, and JMC, in which placebo was better in JMC, and Pilot was just at the center. So the all-cause mortality was better by use of ACE, whereas in the ARB trials, renal, IDNT, life, scope, value, MOSES, PROFESS, Transdent, ACE, Keto, and Navigator. You just see a marginal difference in few trials, but most of the trials were either in the center of the forest graph or control was better. So ACE inhibitor was associated with a statistically 10% reduction in mortality, 20.4 versus 24.2 deaths per 1,000 patients, which was a hazard ratio of 0.9 and a 10% reduction in mortality. Whereas in the ARB group, there was no significant mortality reduction demonstrated. 13 trials, 22 deaths per 1,000, a hazard ratio of 0.99, and so there is p-value of 0.6 and no significant benefit on mortality by use of ARB. Then comparison of angiotensin receptor inhibitor and angiotensin receptor blocker on cardiovascular outcomes in hypertensive patients with type 2 diabetes. This was a PRISMA compliant systematic review meta-analysis published in the Medicine. They showed the ACE-treated patients were significantly reduction in all-cause mortality, 0.87%, that is 13% reduction. CV death by 0.81. All other CV outcomes such as MI, stroke, and heart failure were reduced by the use of ACE inhibitors. And the CV events also were reduced, whereas ARB showed no significant reduction in results of many primary and secondary outcomes. So they concluded ACE showed a significant reduction of CV protection for all cause, CV death, major CV events, whereas ARB did not show this. Dr. Karunakar now, based on the meta-analysis data, ACE were found to be beneficial. So what is your opinion based on the BP-LTT trial? Do you think ACE inhibitors have a BP independent effect in reduction of vascular events such as cardiovascular, MI, stroke, and hypertensive? Then based on Van Wark 2012 analysis, do you consider ACE inhibitors for reducing all-cause mortality in hypertensive? And according to the Zandine 2018 analysis, do you prefer ACE in diabetic hypertensive population for reducing all-cause mortality? So, Dr. Karnakar, you have to answer 3 questions. Depending on the data given to you, what is your opinion?
Yeah, the largest meta-analysis of all the BP therapies. So BP blood pressure lowering trials, blood pressure lowering therapy treatment trials collaboration, which was very large trial, BPL TTC. So yeah, all the questions
One by
asked
one.
were, yeah, I think yeah. I think the first question is about BPL TTC. So BPL TTC was the largest meta-analysis of all the trials of BP reduction involving various agents, including ACE inhibitors, calcium channel blockers, beta blockers, diuretics, all those things they have tried. And in this, ACE inhibitors proved its effectiveness beyond the BP control. So when they have taken very high risk patients for heart disease, surprisingly, the heart disease complications rate reduced among the ACE inhibitor used patients. So that's why they concluded that ACE inhibitors effectiveness is beyond the BP control. So that is proven in this trial, and that is well accepted. This was published in 2006 itself. So since then, ACE inhibitors are considered not only for BP reduction, for all sorts of cardiovascular risk reduction among the high risk patients. So that is about the first question. The second question is about the Van Werk trial, right, sir?
Yes. Do you consider ACE inhibitor for reducing all-cause mortality in hypertension?
Yes. In even in hypertensive patients, it has proved very clearly from the Van Werk trial, that study, it has reduced the all-cause mortality in high-risk patients. And from the latest trial, that last one, in diabetic patients, in high-risk diabetic patients.
Yeah.
So ACE inhibitors, uh, like ACE inhibitors proved their effectiveness among all sorts of high-risk patients, and even with or without high BP. So that's a very good advantage with the ACE inhibitor usage.
Basically, what we could make out is I think ARBs are basically good anti-hypertensive drugs, but when it comes to reduction of CV events, MI or mortality, you should go back to ACE inhibitors,
ACE
and they
inhibitors
will
will have
definitely
probably a
prove
pleiotropic
that.
like thing.
Yeah,
Yeah.
pleiotropic effect is better. Dr. Deepak and Dr. Vinod, would you like to add any comments? One by one, you can tell.
One important mechanism of action of ACE inhibitors, which is lacking in the ARBs, is that angiotensin converting enzyme inhibitors also prevent the breakdown of vasodilatory molecules, which make
Yes.
bradykinin and other smaller molecules, which is also the reason why it causes cough, dry cough as a side effect. But these vasodilatory peptides also have a certain beneficial effect, which is not there with ARB. ARB just blocks the receptor. It may cause a drop in blood pressure, but the vasodilatory effects of ACE inhibitors are not there. That could also be one of the additional reasons why ACE inhibitors have been found to be better compared to ARBs.
Yes, definitely. And as I showed you in the slides, in the what you say plaque ACE inhibition and what you say the mediators also are better tackled with ACE inhibitors because they inhibit angiotensin 2, and so pi1 is reduced, that is thrombosis risk is reduced, inflammatory markers are reduced, that is VCAM and ICAM things, and endothelin also is reduced. So basically, we plaque ACE hypothesis favoring a better anti-atherosclerotic and anti-hypertensive effect, which is seen in the ACE and not seen with the ARBs. Dr. Vinod, do you want to add something?
Yes, sir. I go with sir, because it has the anti-inflammatory property, anti-atherosclerotic property,
Correct,
which is
correct.
not there with ARB. And
Yeah.
all-cause mortality benefit is always stands with ACE inhibitor. So obviously, when I have multiple comorbids, when I have to choose a drug for hypertension, I always want to deliver a mortality benefit to my patients too. So my first initial choice would be ACE inhibitor. And even in among CKD patients also, this stands good. So obviously, this is a drug of choice when we talk about hypertension.
Yeah. Let us go to the third part of the story.
Hello.
1 minute. Share screen.
Sir,
Yeah.
that's it from my side, sir.
So going to the next part of the story, ACE inhibitor versus ARB at risk, emerging evidences over the decade. We have a trial called as value trial and something which is old but definitely very perturbing, ARB-MI paradox concept. So we'll see the difference of opinion of our panelists. Now, this is an important trial. In the value trial, where they found there is something called as an ARB-MI paradox. It was an unexpected relationship of angiotensin receptor blocker with MI, may be aptly described as ARB-MI paradox, and was first raised as an issue in 2004. It contained 15,245 patients, 50 years of age, treated or untreated hypertension at a risk of cardiac events. A randomized double-blind parallel group comparison of therapy based on valsartan and amlodipine was done. The primary composite endpoint of no significant difference of cardiac morbidity and mortality and for all-cause mortality were noted between the treatment groups. The amlodipine had significant lower incidence of MI and higher rate of new onset diabetes than the valsartan group. You can just see the curves. The blue is valsartan and the yellow is amlodipine. The valsartan is definitely having more problems than the amlodipine. And the study group 0 to 3, 3 to 6, 6 to 12, 12 to 24, 24 to 36, 36 to 48 months, and the study end. The change of systolic BP 2.2 to 1.7. The primary endpoint favoring valsartan was there, whereas favoring amlodipine was there in about 3 to 12 months. Then most important, which was paradoxical, was this. The incidence of MI was seen at about 12 to 24 months, and the value trial predicted MI of about 0.098 with a systolic gradient of 2.2 millimeters compared to the observed 1.19, and concluded that regards to MI, the result of valsartan-based treatment was not good than those of amlodipine-based. And they saw this. You can just see the fatal rate in the ARB valsartan group versus amlodipine, the yellow. You had an about 7% of patients experiencing myocardial infarction at the dose of 160 milligrams compared to 10 milligrams of amlodipine, and followed up for almost 66 months. So the relative risk of ACE versus ARB in MI reduction or presence of MI. Patients with irbesartan versus CCB, the incidence of MI was very high in irbesartan group, 54%. Andesartan versus placebo, charm alternative, 52%. Valsartan versus amlodipine, this was the value trial, 19%. Irbesartan versus placebo, eye preserve trial, 11%. Andesartan versus placebo, 10%. Losartan versus atenolol in the life trial was 7%. Telmisartan versus ramipril on target trial was 7%. So all of them were having an increased incidence of myocardial infarction, highest being for irbesartan. Whereas you see ramipril versus placebo or perindopril versus placebo tested in HOPE and Europa trial respectively, the MI reduction was 20% for ramipril and 22% for perindopril. They hypothesized ACE versus ARB in this Venn diagram. You can just see angiotensin increased renin activity, ACE inhibitor given, acts at the 81 receptors, substance P and bradykinin were increased, nitric oxide was increased, prostaglandins increased. Then when we come to ARBs, 81 to 1 to 7 receptors and aldosterone was there. The beneficiary effects of ACE, vasodilation, anti-aggregation, anti-proliferative, stimulates PA synthesis, cytoprotection, and endothelin and plaque stabilization was seen, whereas non-beneficial effects of ARB, effect on AR, hypertrophy, remodeling, plaque instabilization, inflammation reduction, increased expression of I1, endothelial dysfunction were seen. The probable biological plausibility for this paradox is basically AT2 receptor promote the plaque rupture by augmentation of metalloprotein activase 1, and that causes increased MI in ARB group. Then do ARB increase the risk of MI? A meta-analysis for Strauss, MH et al. Showed ACE inhibitors versus comparator in 39 trials, including 150,000 patients, 9% reduction of global death, 12% reduction of CV death, 6% reduction of stroke, and 14% reduction of MI. Whereas if you use the ARB, there's a 1% increase in global death, CV death by 1%, only stroke reduced by 8%, whereas 8% increase in the comparator MI. So 11 trials, 55,000, this is the data, and statistical significant value. So Dr. Vinod, ARB-MI paradox, is it a real paradox or reality or a myth? And in patients with chronic coronary syndrome with hypertension, what will be your choice of antihypertensive drug, ARB or ACE? Kindly give answer to these questions.
Sure, sir. Sir, AC ARB paradox, MI ARB causing MI is been discussed for quite long time. And I remember an article being published in Circulation in 2017, where they published a debate between Stars group from Canada and as well as Bangalore from New York group. So they both had their points towards the favoring and against these two aspects of AC and ARB, whether ARB is increasing MI. So first I will give the perception from that article. Next I will highlight what I feel. So the article, the favoring points from Stars group for Bangalore group for ARB was that they said when ARB was tested, the patients had a baseline therapy which was really improved, like they had statins, other system drugs which can reduce contemporary cardiovascular risk. Whereas when AC inhibitors were tried, it was independent. The mortality risk was extremely high during that time. So the addition of this drug was able to bring down the significant reduction in MI. But this ARB paradox value trial, as you have been mentioned, it was compared between amlodipine as well as ARB. Other than that particular trial, there is no absolute increase in MI. There is a relative risk increase, relative risk rise of MI incidence with ARB. And they put a point saying that when ARB and AC inhibitors are compared with each other on a single head-to-head trials, those trials did not show a absolute increase in MI or all-cause mortality between these two drugs. That is what their stance. So what was Stars was saying, there is no actual data to prove that ARB was superior. None of the trials showed, as you mentioned, all-cause mortality benefit. So though since it was a newer drug, multiple companies were pushing for this particular drug because it is that time ARB AC was a generic molecule during that time. That's why it was lacking the data. Still, it was being widely used as a antihypertensive medication. This is where their status. I also personally feel, sir, when we talk about none of the major trials is not saying ARB can give all-cause mortality. Though it, we can say that there is no strong evidence that 100% if I use ARB, MI will happen. But there is no trial which says that, like ACE, addition of ARB will reduce the risk of MI. So there is no all-cause mortality benefit. There is no benefit in terms of MI reduction, where I have another drug, equivalent drug, which shows clearly there is a benefit in terms of MI reduction and all-cause mortality reduction. Of course, my choice would be AC inhibitor if the patient is tolerating. Unless if the patient is not tolerating, I will switch to ARB. Otherwise, even now, today, my choice of first line of therapy is going to be AC inhibitor. This is my the first question, sir. Second question, undoubtedly in CCS, where we all know there is a risk element of risk even after revascularization is about 15% in a CCS patient. So I don't want a recurrence of event among this CCS patient where I have to be more careful. My choice of drug would be AC inhibitor rather than ARB, where ARB has never shown mortality or morbidity benefit in terms of cardiovascular safety. So in both the cases, my choice is going to be AC inhibitor, if not tolerated ARB.
And if the blood pressure is not controlled, would you switch on another antihypertensive drug, or will you change to ARB in your cases of
Sir,
MI?
most of the guidelines. Sir, now if that is the case, ACE inhibitor in MI, sir, in regular hypertensive patient.
In MI. We are discussing
In
MI.
now we have ARNI. So I will switch when AC inhibitor in full dose. I'm not able to control the BP. Probably I will take other drug, or if there is a pre-existing post-MI patient, LV dysfunction is there, then I will even switch over to ARNI, which is a better hypertensive control drug, because we struggle to give hypertensive drug ARNI in patients with LV dysfunction, where patients go in for hypotension. But if the patient has an LV dysfunction post-MI and I'm not able to control his hypertension, then obviously, in spite of Ramipril 10 mg, then I will 100% switch to ARNI, where I have the liberty to use the 200 mg drug, 100 mg BD, and then to update it to 200 mg. Mostly the BP should come under control. Before ARNI, obviously I would have chosen a CCB. Now, with the presence of ARNI, obviously I will try ARNI, sir.
Dr. Deepak, do you have any addition points to the points given by Dr. Vinod?
I agree. He gave a very detailed and comprehensive analysis of ARB versus ACE inhibitor, and I agree with all the points. One of the reasons again could be that when you block angiotensin receptor, there is a reflex increase in the angiotensin 1 and 2 levels, which probably drives the paradox of MI. Nobody really knows. But data and whatever with evidence available, ACE inhibitors should be our first choice, and only if not tolerated should be switched over to ARB, or like Dr. Vinod told, to an ARNI if the indication is suitable.
I think the take-home message at this level is ACE inhibitors cannot be interchanged with ARB unless there is a side effect, and try to use ACE inhibitors in ACA situation, because there is something called as AMI paradox seen with value trial, in which we were definitely experimenting valsartan with amlodipine. So let's go to the next part of the story.
And I think the main thing which drives ARB usage is the fear of side effect, which is cough.
Cough. Basically,
more than anything, it's the fear of side effect. Even before trying ACE inhibitor, many people write ARB just to avoid the cough.
Correct.
Which is very less in routine or daily practice. That is
no. It is there. Cough incidence is fairly high.
But not like 50%, not like that, sir. Only probably 10 to 15% we see in our.
Correct.
Fear of edema, straight away cilnidipine. Fear of cough, straight away ARB. So you see the commonest prescribed antihypertensive is cilnidipine with some ARB.
Yeah, definitely.
Very true.
They have really picked up. So going to a high-risk population subsets, based on the on-target study, should telmisartan be considered bioequivalent or a non-inferior alternative? What the healthcare professionals should know about this, let us see in detail. On-target and Transdent, these were the two important trials where we were comparing ARB, ACE, and a placebo. Now, they had a follow-up of 3.5 years to 5.5 years. High-risk population with previous vascular...
Sir, we can't see the slide.
Oh, 1 minute. Let me go back.
Should share the screen.
I think so. I made a mistake. What's the error I have made? 1 minute. Share screen. Yeah. Now visible?
Yes, sir. Yes, sir. It's visible now.
Now visible, no?
It's
Yeah.
visible, sir.
Fine. So we were testing this hypothesis based on the on-target study. Should telmisartan be considered bioequivalent or a non-inferior alternative? So what should be the healthcare professionals know about the hypothesis? Now, two trials, on-target and transdent, they were 3.5 to 5 years follow-up, having high-risk patients with previous vascular event, diabetes with target organ damage, but controlled blood pressure and no heart failure. They were non-heart failure patients. Tolerating the ACE, they are yes. They were put into on target 23,400 patients, 3-week run. They were either given telmisartan to 7,800, ramipril 7,800, and a combination of telmisartan with ramipril 7,800. If they are not tolerating ACE, then they were given, included in the transient trial, 6,000 patients, 3-week run, telmisartan 3,000, placebo 3,000. The primary outcomes were to compare composite of CV death, non-fatal MI, non-fatal stroke, hospitalization for congestive heart failure, and the secondary outcomes of newly diagnosed congestive heart failure, revascularization procedures, newly diagnosed diabetes, development of dementia, cognitive declines, nephropathy, or newly diagnosed AF. Other outcomes, all-cause mortality, non-CV death, angina, TIA, development of left ventricular hypertrophy, microvascular complications of diabetes, and changes in BP and in ankle arm BP ratio and malignancy were studied. Going to the study results, ARB is found to be non-inferior to ACE for reducing risk of major CV events, including CV deaths. This was published in NEJM in the year April 2008. The ARB achieved a lower BP than ACE, about 0.9 by 0.6, but also showed a non-significant trend of 7% excess of MI, as we have already discussed. So if you take ramipril, telmisartan, or a combination, death from cardiovascular causes, myocardial infarction, stroke, hospitalization for heart failure, in the ramipril group was about 16.5%, 1,412 patients versus 16.7, 1,423 patients in the telmisartan, and in the combination it was 16.3%, 1,386 patients. Whereas in the transient trial, it was slightly different. Then death from cardiovascular cause, myocardial infarction or stroke, in ramipril group was 14.1 versus 13.9 in telmisartan group. In combination, it was 14.1. MI 4.8 versus 5.2, ramipril versus telmisartan, ramipril scoring over telmisartan. Stroke 2.7 versus 4.3. Hospitalization for heart failure 4.1 versus 4.6%. Death from cardiovascular causes was same. Non-cardiac causes was almost same, and from any cause also was roughly the same. So see the difference in myocardial infarction. In the ramipril group, it was 4.8%, 413 patients out of 8,500 patients, and 440 patients, 8,542 patients. So 4.8 versus 5.2%. Did not achieve a statistical significance, but the trend was definitely in favor of ramipril. The evidence from transdent study, no significant reduction in primary composite outcome of cardiovascular death, MI, stroke, hospitalization for heart failure was seen between ARB versus a placebo. You can just see ARB in the blue, red, and placebo in the blue for 5 years. Then comes the important HOPE and Europa trial. HOPE was comparing ramipril and Europa was comparing perindopril. Both are lipophilic molecule, have high affinity for receptor sites on ACE molecule, and provide greater penetration into the atherosclerotic plaque. So HOPE was done in 2000 and Europa in 2003. Incidence of primary outcome and death from any cause. In the HOPE trial, where ramipril was comparing with the placebo, myocardial infarction, stroke, death from any other cause was 0.78%. Death from cardiovascular cause was 0.74%, favoring the use of ramipril. Then stroke was 0.68, that is favoring the use of ramipril. That is 3.4 versus 4.9% if you see figuratively. MI 9.9 versus 12.3 in the placebo. Again, a 20% reduction. Then death from cardiovascular cause 6.1 versus 8.1%. A relative risk reduction of almost 26%. Whereas you go to the Europa trial where perindopril was the molecule, you again see cardiovascular mortality, MI, and cardiac arrest reduction of 20% by the use of perindopril. The cardiovascular mortality 14%, non-fatal MI 22%, and total mortality by 14%. So comparing HOPE and Europa, HOPE had about 9,200 patients. Of them, 38% were diabetics, 47 were hypertensive, 42% has peripheral arterial disease, and 10% had stroke. In Europa trial, the incidence of diabetes was on the lower side, 11.8%. Hypertension was on the lower side, 27%. Peripheral arterial disease was lower, 7.1%, and stroke was 3.4%. The area Europa was only in the European region, whereas this was conducted in North, Central, and South America and Europe. Mean age was 66 years and 60 years respectively. Mean BP was 139/79 and 137/82. Female population was higher in HOPE, 27% versus 14%. With the background therapy of beta blocker, antiplatelet, and lipid lowering drugs in these percentage of cases, 39, 75, and 24. The number needed to treat was 3.5 years, 50 in the Europa group. Dr. Deepak, in nutshell, what is your key message to our audience for high-risk population?
I think the data is very conclusive that in high-risk population, one needs to give ramipril and strive to achieve a dosage of 10 milligram per day is when the RAS inhibition as well as the pleiotropic effects, anti-atherosclerotic effects, and plaque modifying effects become more optimal.
What is your experience with perindopril?
Perindopril we have used, not much. Most of our experience.
It's more of a neurologist drug in strokes.
And I think the other important thing is perindopril is not as widely available as ramipril also, except for one or two brands. Not really widely available. Even when we have prescribed at times, patients have come back saying it's not available, change it to something, and we end up changing it to ramipril. So earlier we used to use more of enalapril, and once ramipril, the HOPE trial came, I think ramipril has completely taken over the ACE inhibitor share. I would say 90% of all the ACE inhibitors prescribed is ramipril, or more than 90%.
Okay. Dr. Karnakar and Vinod, do you want to add anything to this high-risk population? What is your choice of drug? Ramipril, perindopril, or an ARB?
So obviously all the trial data is backing the ACE inhibitors. So we try ACE inhibitors first. If any contraindication, if any complications, if any side effects are occurring, then we'll switch over to ARBs. So that is the standard of the care.
And Dr. Binod, do you want to add something?
So I agree on the same, sir.
I think so. We can proceed to the next.
Yes, sir. Yes, sir. True, sir.
Yeah. Able to see the slides? You're able to see the slides?
Yeah, we are able to.
Go ahead, sir.
Yeah.
Yes, sir.
So the next subset is post-MI. Evidence of mortality benefits, ACE versus ARB will be discussing. And the key evidences, we have various trials in the last 1 decade, rather more than 1 decade, now 3 decades it is. So the first to show the effect of what we say ACE inhibitors in a post-MI situation was the SAVE trial, published in 1992. 2,200 patients where captopril was started between 3 and 16 days after MI and found to reduce mortality and morbidity. Then came in 1993 the AIR trial where ramipril was used, 2006 patients between 3 to 9 days after MI, and they found to reduce the mortality. Then came the TRACE trial, 1995, which used trandafil between 3 to 7 days after MI, with reduced LV function and effectivity. This mortality from CV cause, sudden death, and development of heart failure was reduced by use of trandafil. So these 3 trials, very important, ACE, AR, and TRACE. Duration of trial for SAVE was about 3 years. IR was about 3 years, and TRACE also was about 3 years. Molecules they used were captopril, ramipril, and trandafil in dosage of 50 milligram TID for captopril, 5 milligram BD for ramipril, and 4 milligram once a day for trandafil. The number of patients were about 2,000 in each subset. Selection day was important, 3 to 16 days after MI in the captopril, 3 to 10 days, and 3 to 7 days in trandafil group. Selection criteria, EF less than 50 as assessed by radionuclide MUGA scan and no symptoms of heart failure were in the patients. Then patients with clinical evidence and radiographic evidence were included in the IR group. And echocardiographic evidence for LV systolic dysfunction less than 35 were for TRACE. Age group was 21 to 80 years, more than 18 years, and average follow-up for SAVE was 42 months, 15 months for IR, and 24 to 50 months for TRACE. So coming to each trial, SAVE trial, survival and ventricular enlargement study. It was a double-blind, placebo-controlled multicentric trial where setting of the patient was MI with LVEF less than 40%. The EF was determined by MUGA scan at baseline and at 36 months. And the drug was started between 3 to 16 days, captopril, in a dose of 50 milligram TID. Mean follow-up of 24 months to 60 months. Captopril showed 19% reduction in mortality and 25% reduction in recurrent MI. The dilatation of the cavity, LV cavity, was reduced, and the benefits occurred equally in patients who received lytic therapy and beta blocker in who did not receive it. So you can just see captopril having the effect up to 4 years, and the curves continue to separate with placebo. The IR trial was acute infarction ramipril efficacy. It was again a double-blind, randomized, placebo-controlled trial in a setting of MI with the EF of heart failure patients, and they started between 3 to 10 days. Oral ramipril 5 milligrams twice a day, 15 months follow-up, and what did the results show? There was a 27% decrease in mortality, 19% reduction in the rate of MI and stroke at the end of 6 months, published in Lancet 93. Then there was something called as an IR extension study, 603 patients up to 42 to 59 months follow-up, and beneficial effect of ramipril started early after MI with heart failure are sustained over 3 to 4 years despite discontinuation of medication at the end of 1 year. This is very important. Even though the patient discontinued at the end of 1 year, there is a continued effect of this drug up to 3 to 4 years. The TRACE trial, trandafil cardiac evaluation study, AMI with reduced ejection fraction. The drug started between 3 to 7 days, 1 milligram per day increased to a max of 4 milligrams, 24 to 50 months follow-up, 15% reduction in mortality, 20% reduction in MI. Then we move on to ISIS-4, where captopril was effective in reducing 5-week mortality was studied, found out. The famous GC3 trial 18,000 patients, lisinopril started after 24 hours after MI. This is very important. We are coming down on the starting time of this drug post-MI. Now, this is within 24 hours. Effective in reducing mortality and severe LV dysfunction. Then the CCS1 trial, anterior MI patients on captopril was found to have lower mortality. Then optimal trial 2002 studied losartan 50 milligrams once a day versus captopril. There was a non-significant difference in total mortality favoring captopril. Valiant trial 2003, valsartan is effective as captopril in patients who are at high-risk CV events after MI. Combining valsartan with captopril increased the rate of adverse event without improving survival. So this was optimal trial 2002. In myocardial infarction with angiotensin 2 inhibitor losartan, there was a non-significant difference in total mortality favoring captopril. You can just see. Captopril was straight and this is dotted line. Okay. Non-significant favoring the, captopril use. So therefore, it has proved ACE inhibitors are still the first drug of choice in acute complicated MI. The Valiant trial 2003, mortality from any cause and cause-specific mortality were similar in the three treatment arms, captopril, valsartan, and combination. The rate of secondary endpoint of death, cardiovascular cause, recurrent MI, hospitalization for heart failure was same in all the three groups. Question to Dr. Karunakar. In a post-MI situation, after seeing the result of these three trials, what is the preferred therapy you would like, ACE or ARB?
So here also the same principle applies. Unless there is a contraindication, ACE inhibitor is the preferred choice. So all the trials have proven the same thing, especially in patients with high-risk features. Whenever patient is having low ejection fraction or CKD or other diabetes, so these patients benefit with ACE inhibitor exceeds the ARBs. So ACE inhibitor is the preferred therapy unless there is a contraindication, as we discussed so far, unless the patient is not tolerating because of the cough or because of hypotension or because of other reasons, because of angioedema in the past, if something is like that. Otherwise, the ACE inhibitor is clearly the choice and recommended by all the guidelines.
How early you started? Day 1, day 3, day
yes,
7?
Yes. Unless the patient is having hypotension or unless patient is having any issues, the early is the better. Actually, we can start as early as possible unless
within 24 hours is the best.
Best.
Dr. Deepak, do you have anything to add on this point?
In fact, evidence is very clear that ACE inhibitors are the drug of choice in post-MI left ventricular dysfunction to prevent heart failure, to reduce hospitalization, and to reduce mortality. In fact, Paradise MI trial also showed that ARNI, in fact, post-MI does not reduce heart failure, does not reduce hospitalization compared to ACE inhibitor. So in the post-MI period, ACE inhibitors have to be the first choice in preventing mortality.
Yeah. Dr. Vinod, do you want to add anything, or you accept the fact that ACE is the drug of choice and earlier starting is the better, within 24 hours if there is no hypotension and no side effects?
If the patient is not on inotropic supports, and if the patient we are able to initiate, we have to initiate within first 24 hours. No doubt, all the guidelines across the globe states ACE inhibitor is the class 1 indication, and it has to be initiated within 24 hours in patients with MI, with acute MI with LV dysfunction. As beautifully pointed out by Paradise MI trial by the previous speaker, it's very clear that in acute MI situation, AC is the king. So there is no doubt ACE inhibitor should be the choice.
Yes, I think that is the message we are giving to the physicians who are seeing this symposium. And ACE inhibitors undoubtedly are the drug of choice post-MI and should be initiated as early as possible within 24 hours if there is no inotropic support and blood pressure favors it. So let's go to the next point. షేర్ రాలేదు షేర్ రాలేదు go back and then come back share Are you able to see the slides?
Yes, sir.
Yeah, visible, sir. So now let us see what the major clinical guidelines say. Post ST elevation MI 2007 ESC guidelines and ACC AHA 2013. ACE inhibitor for ST elevation anti-revolve MI EF less than 40. Early heart failure, diabetic hypertensive. It's a class 1 level of evidence A. ARB for EF less than 40%. Early heart failure, diabetes, hypertension. It is still level of evidence B. And ACE inhibitors for ST elevation MI within 24 hours, unless contraindication, is stage 2A level of evidence A. So this is the difference we have in the initiation of these drugs. Anterior MI, EF less than 40, it's a class 1A. If you want to start ARB, it is class B. Level of evidence is B. Less than 24 hours, still it is a 2A at the 2017 and 2013 ACC ESC guidelines. Then coming to 2020 ESC guidelines for ACS management, presenting without persistent ST elevation, ACE inhibitors or ARB, in case of ACE intolerant patients, recommended in patients with heart failure with reduced EF. They are diabetic, CKD, unless contraindicated, in order to reduce all-cause mortality and cardiovascular morbidity. It's a class 1 level of evidence A. Beta blockers are recommended with LV systolic dysfunction and heart failure and MRS. These are all class 1A indications, but we are discussing ACE-ARB, so we'll restrict to this. Now, most important, what our take-home message should be, illustration of time-dependent therapies for post-MI heart failure patients. Index MI, 0 hours, initiation within 24 hours, 40% survival benefit from ACE is reaped if you start on day 1. Then early introduction of aldosterone antagonist, MRA, benefit in time should be started within 7 days of index event. And critical to titrate the dose of medication, that is ACE, beta blockers to optimal levels in post-discharge is very important. So immediate perfusion for ST elevation, early revascularization for cardiogenic shock. We should avoid beta blockers in the first 24 hours. And most important is reevaluate for eligibility at within 7 days of post-MI. This is what is the take-home. Start ACE inhibitors if there is no inotrope and features blood pressure favors within 24 hours, MRA within 7 days, and titrate the dose to the tolerated dose of ACE and beta blockers pre-discharge. Early ACE offers maximum therapy benefit. And post-MI infarction heart failure, this is the JACC acknowledges higher, the first ramipril study. And most important is it should be administered within 24 hours, EF less than 40%, significant survival benefit is seen. And Dr. Vinod, will you start ACE in all the patients with ACS, whether revascularization procedure was performed or not, to get mortality benefit?
Sir, I think in between sir disconnected. I think you go ahead, sir. Yeah,
Huh?
maybe. I think sir is not audible. Maybe Karnakar sir can take this. Yeah.
Karnakar, you want to take the question?
Yes, sir. So
Despite revascularization, will you start ACE or ARB?
yes, sir. So the revascularization is to prevent subsequent heart failure and all. But to manage the initial MI and its complications, it's better to start ACE inhibitor as early as possible, irrespective of revascularization status.
Okay. So it is important that even if you have done a PCI or given thrombolysis, you should start this medicine.
Very
Yes, sir.
independent mode of treat therapy, we are asking, we are providing for a STEMI patient. There is no doubt this should be our choice. AC inhibitor, as mentioned in every guideline, it should be the drug of choice and it has to be initiated. And I hope most of the centers are initiating. Yeah.
That is the important message we have to give.
Yeah, they have to, all physicians have to initiate, unless otherwise it is contraindicated. The patient should receive a AC inhibitor, undoubtedly. Probably if the pressures are on borderline, don't worry, go with the lowest possible dose.
Sure,
Unless
sure.
the patients are on not on inotropic supports, and if you want to start the medications, there is always you have to start 2 drugs first 24 hours. If the patient is not on cardiogenic shock and the patient is not on failure, pulmonary edema, full-blown pulmonary edema, the 2 drugs has to go in. One is AC inhibitor and beta blocker. Both have an excellent mortality and morbidity benefit at the first 30 days. So please initiate the lowest possible dose. We need not rush for the maximum dose at the initial stage, but try to introduce the patient on both these drugs before shifting the patient out of ICU. Because there might be a miss in increasing or initiating a new molecule. So always it should be an habit before patient being shifted from the ICU. The patient should be on a AC inhibitor as well as a beta blocker. That would be my message, sir.
Thank you. Thank you, Dr. Vinod. Yeah. Now, the important one, what Dr. Deepak was telling, angiotensin receptor napitalization inhibition. This is the army, what we were talking of. Following an AMI, the primary result of Paradise MI trial, published by Mark Pfeffer. You can just see India was a part of this trial. We had 330 patients from this part of the continent. It was 5,600 patients, 495 cents, 41 countries. So it's a very well, what you say, trial comprising of the global population. Sacubitril valsartan 76 and 24 milligram respectively, 2,800 patients, ramipril 2,800 patients. Reperfusion by PCI or lytic was almost in 89% of the cases, 89% and 89% in the ramipril group. Then location, anterior infarction in 68, inferior infarction in 19. Similar strategy. EF was 36 and 37. So baseline characteristics of both the drugs were almost same. Phillips class 2, 56 versus 57. Dual antiplatelet drugs in both the groups. Beta blocker, MRA, statin, ACE was there in both the groups. What was the outcome? CV, death, first hospitalization, and outpatient heart failure risk. You can just see this is the ramipril group, 373 events, 7.4 per 1,000 patient years. In sacubitril valsartan, it reduced to 338, representing a hazard ratio of 10, p-value of 0.17, and a 10% reduction in the cumulative incidence rates by the use of this drug. Now, primary outcome in the sacubitril valsartan 338 versus 373 in the ramipril group, a hazard ratio of about 0.90, representing 10% decrease in the event rate. Patient with CV death 5.9% versus 6.7%, 13% reduction. Heart failure hospitalization 6 and 6.9, a 13% reduction. And outpatient heart failure 1.4 and 2.0, a 32% reduction with the use of sacubitril valsartan. The CV death Hospitalization for heart failure, 10.9 versus 11.8, 9% reduction. On an outpatient basis, 7.1 versus 8.4, 16% reduction. CV death, non-fatal MI and non-fatal strokes, 11.1 versus 12.1%, a 2% reduction with the use of sacubitril valsartan. All-cause death, 7.5 versus 8.5% and a 12% reduction with the use of sacubitril valsartan. Adverse events, angioedema was almost the same. Serious adverse events, 40.5% versus 39.8%. Hypotension, cough, renal impairment, slightly more in the ramipril group than the valsartan group. Renal impairment was same, hyperkalemia was almost the same, liver abnormalities same. So basically, the incidence of hypotension and cough was less in sacubitril valsartan. Permanent steady discontinuation, excluding the deaths, less in sacubitril group. The incidence of cough was 1.2% versus 2.3, and hypotension 1.3 versus 0.6. So slightly more hypotension in sacubitril with less incidence of cough in sacubitril group. The Paradise MI all death better with sacubitril valsartan, 12% reduction with a p-value of 0.16. So in summary, sacubitril valsartan did not result in significantly lower rate of CV death, heart failure hospitalization, or heart failure requiring treatment. He specified observation of reduction in both the investigator report and the primary composite was there. The safety and tolerability of sacubitril in this AMI population was comparable to the ACE. In the Medscape, if you see comments post release of Paradigm MI headlines, makes me the question the benefits of sacubitril valsartan. ARNI does not surpass ACE after acute MI. These are the two major things which were questioned. Sacubitril valsartan misses significant heart failure event reduction mark in Paradise MI. Safety profile of ACE. To all the panelists, the cough reported in the Paradise MI was 13% in ramipril versus 9.5% in ARNI, and cough as a reason for discontinuation, 2.3% in ramipril versus 1.2 in ARNI. What is the incidence in your practice? Dr. Deepak, Dr. Karlakar, and Vinod, you can answer independently one by one.
Sir, myself, Vinod. Sir, I feel in general practice, the cough with AC inhibitor undoubtedly is slightly more when compared to that of ARNI. That is what I feel. I don't head up with a lot of cough in my patients. But the main problem with ARNI, what I face in my day-to-day practice is hypotension. So most of the AMI patients who have a borderline BP, initiating them on ARNI is going to be quite a challenge initially post-MI. Even though patient has a significant LV dysfunction, the BP threat is very low. So initiating is going to be very, very difficult. So I will put this way. When cough alone, what was the trial setting? I'm not sure. But if you ask me only on cough, I will still rate AC inhibitor as more cough when compared to that of ARNI.
And do you attribute all this cough to ACE inhibitor, or do you attribute other reasons to cough, like what you say, paroxysmal nocturnal dyspnea,
Failure.
venous congestion?
Yeah, PND, because patient on the initial phase, they will have failure signs, minimal failure signs, PND. You will not be able to optimize them very easily. You will be trying to switch them from IV diuretic to oral diuretics. And on oral diuretics, the drug optimization is going to be a challenge. So during that period, obviously a cough could be because LV failure.
Sure. So I think everything is not ACE inhibitor, but probably 80% to 90% is ACE related. Okay. Hello.
I lost my questions.
Yeah.
Sir, am I audible, sir?
Yeah, you're audible. You're audible.
Yeah. So I think my connection got cut, sir. Sorry.
No problem.
I strongly believe there can be multiple reasons why a patient to develop a cough. But it is very difficult in day-to-day practice to initiate ARNI on a ICU patient immediately after post-MI. That's not, I can very sure, and I will be able to comfortably start the patient on AC inhibitor without any major hindrance in almost all the patients post-MI. That is possible and feasible. So that much very sure, sir.
Dr. Deepak
Paradise is one such thing which clearly showed that.
Do you differ in the
Paradise
comments of Dr. Vinod, Dr. Deepak, Dr. Karnakar?
I think I agree with Dr. Vinod. The incidence is more or less the same as published in this trial.
Yeah.
And not all cough is attributable to ACE inhibitors. And most of the time, if you explain and continue, many are able to continue without much of a problem. It is not always necessary to stop and change.
Sure. Dr. Karnakar, do you have any difference in
Yeah.
opinion? Or,
No, sir. I
the same?
fully agree with the trial data. We have never calculated in our practice how much is the cough and all, but as I discussed, as I told you earlier, it's about 10 to 15% only, not
Yes.
in every patient, and that too, cough severity varies. So
Yes.
if it is a mild cough, something like ARNI, the patients will cough some breathlessness. Okay.
Yeah.
Yes, something like that. So if it is tolerable, still we encourage them. Suppose it's like a Brilinta cough, Brilinta breathlessness, something
Right.
like that. So if it is tolerable, we tell them it's because of this, but this drug is going to help you. If you
Yes.
make them understand
So,
the reason and
motivate the patient to continue to use unless
continue,
it is
then
distressing.
yes, then okay. And as other colleagues discussed, cough in ICU could be because of so many reasons in the post-MI.
Correct.
So we have to look for other alternative causes. We have to work up. And finally, the final question, C part of this question, de-challenge and re-challenge test. Sometimes we can test that we can withdraw and we can de-escalate the dose of the ACE inhibitors. Then we can see. And sometimes we can re-challenge them after stopping the therapy for some time.
Yes.
So
I
all
think
these are possible as we see with other drugs. It's possible with the ACE inhibitor also.
So the take-home message is our ACE inhibitors definitely have a 10% incidence of cough. Look
Yes.
for other reasons of cough like pulmonary venous hypertension, infection. But still, ACE is one of the important reasons, and you can definitely try de-escalation and re-escalation of the therapies.
Yes.
So now the take-home message, I think, after a very fruitful discussion with all our esteemed panel, Dr. Deepak, Dr. Vinod, and Dr. Karnakar, I think in patients with hypertension, ACE appears to have BP independent effects on risk reduction of MI, CV mortality, and all-cause mortality. This has been reported in multiple meta-analyses like BP, LTTC, Van Vogt, and Ziordan. In high-risk CV patients for primary prevention of CV reduction, ACE have a proven benefit in reducing risk of MI, CV mortality, and stroke, as seen in the HOPE, PROGRESS, and Europa trial. Similar benefits were not seen with ARB. In most of the patients with post-MI LV dysfunction, ACE has consistently shown to reduce CV death and all-cause mortality, as shown in SAVE, TRACE, ISIS-4, GISI-3, and CCS-1. For reducing progression of atherosclerosis and maximum benefits in MACE, it is important to achieve target dose. That is a very important take-home message. Try to achieve 10 milligrams of ramipril dose. In post-MI patient, only one trial has shown improvement in CV events for ARB, that is the Valiant trial. ARB should not be chosen just because they have a better side effect profile. Paradise MI is the first and only clinical trial for sacubitril valsartan, did not outperform ramipril in post-MI setting. So thank you very much. I hand over the mic to our, organizers and sponsors. MCure, already we are, I think, half an hour
Yes, sir.
post the stipulated time.
I think, sir, more or less, the Q&A has also been addressed throughout the discussion. And, sir, on behalf of MQCV, I would like to thank the entire eminent faculty for, taking this session. First of all, I would like to thank Dr. Rajiv Garg to moderate the session for this evening. And though it's a Monday evening, and we could able to get majority of the audience across Pan India, which were touched almost like more than 300, sir. And let me tell you, and which is a very good number. And secondly, we would like to thank our eminent panelists who has participated in the entire session, starting with Dr. Deepak joining from Bangalore, and we have Dr. Vinod, the associate professor, joining from SRMC from Chennai, and of course Dr. Karunakar from Apollo Hospital. And let me tell you, sir, at at MQCV, we would like to take these kind of sessions going forward, and especially currently on the onset of earnings and all. I think ASS still has got definitely scope going forward, and the way it has been established and endorsed by the entire faculty is totally very much appreciated, sir. Thanks a lot for a great evening for this academic feast, doctor. We'd like to invite you once again for such kind of programs in the future. Thank you on behalf
Thank
of
you,
my
everyone.
entire team also.
Thank
Good
you,
night.
everyone.
Thank you, Team MQ and Raju for
Sure, sir. Yeah.
Thank you
Thanks
so
a lot.
much.
very
Wishing you all very happy New Year and
Sure, sir. Yeah.
hope to see you at CSI Lucknow.
Yeah, definitely, sir. I'll be there. I'll catch you, sir.
Dr.
Thanks a lot.
Karnataka, Dr. Vinod. See you
Yeah,
at
yeah.
Yes,
CSI
sir. Bye, sir.
Lucknow.
Good night.
Yeah.
Good
Thank
night,
you so much.
doctors. Yeah.
Deepak and Dr. Vinod. Yeah, good night.
Good
Thank you.
night. Night.
Nice. Thank you, sir.
Thank you.